Hello, everyone. Thank you for joining me today. My name is Dr. Yamada, and I'm an assistant professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. Today, I'm excited to talk to you about a crucial and evolving model of care, which is geriatric surgery co-management. We will explore what it is, why it's important, and how we can implement its principles to improve outcomes for our older surgical patients. Before we begin, I'd like to state that I have no financial disclosures or conflicts of interest related to the material that will be presented today. So let's start with some background. The concept of co-management is particularly well developed in the field of orthopedic surgery, specifically with patients with hip fractures. This has often been called also geriatrics, and it grew out of a fundamental tension. On one hand, we know that for hip fractures, time is key. The evidence, as cited here, shows that surgery within 24 to 48 hours is associated with fewer complications and lower mortality. The surgical team's primary focus is, rightly so, getting the patient to the operating room promptly. So when the primary team is orthopedics, the timing of surgery is 6.5 hours earlier on average. On the other hand, we have the complexity of comorbidity management. Patients with hip fractures are typically not simple surgical cases. The patients are often older adults with multiple chronic conditions. So managing their diabetes, heart failure, or kidney disease incorrectly can lead to devastating complications. Studies have shown that when a medicine service is only involved as a consultant, it's often difficult to provide comprehensive medical care in a timely manner. We even see high rates of medication errors after discharge. In fact, one meta-analysis showed that when geriatricians managed the admission, patients had lower mortality rates compared to standard orthopedic admissions. This creates a new natural division of priorities. The surgeons are focused on the fracture and the wound, while the geriatricians are focused on the complex medical management. This is a perfect scenario for a co-management model where both teams can work in parallel, sharing responsibility. So this brings us to a formal definition. So co-management is a model that allows a generalist, often a hospitalist, or in our case, a geriatrician, to share the responsibility, authority, and accountability for the medical care of surgical patients. It's a true partnership moving beyond the traditional consultation model. So let's break down the differences between co-management and a traditional consultation because they are significant. So in a consultation, the orthopedics team is clearly the primary team. They decide which patients need a medicine consult, and the involvement is often as needed. The medicine consultant provides recommendations, but the orthopedics team is ultimately responsible for placing orders and communicating with the family. On the other hand, in a co-management model, the roles are shared. The primary team can be program dependent, but both teams have responsibility. Patient selection is often based on a predetermined criteria like age or specific comorbidities, ensuring that high-risk patients are automatically included. The geriatrics team is involved daily from admission to discharge, and both teams can place orders and both teams communicate with the patient and family. This model fosters a much deeper, more proactive, and collaborative level of care. Here's a visual representation of what this process looks like. So number one, it starts with patient selection, where the surgeon and the geriatrician collaboratively identify patients who will benefit. Next is the preoperative evaluation. So the geriatrician conducts a thorough history, physical, and workup to medically optimize the patient before they go to the OR. Then the surgery is performed by the surgeon. This is followed by postoperative care, where the geriatrician actively manages medical issues and focuses on preventing common complications like delirium, infections, and blood clots. Finally, both teams collaborate on discharge planning to ensure a safe and coordinated transition of care. It's a continuous integrated process. So what does the evidence say? Like any model, there are both benefits and risks to consider. The benefits are compelling. Studies have shown improved clinical outcomes, shorter hospital stays, and cost reduction. Perhaps just as importantly, both healthcare providers and patients report increased satisfaction. Surgeons can focus on surgery, and patients feel they are receiving comprehensive care. However, there are potential risks or challenges. If not implemented well, it can lead to fragmentation of care or confusion over roles. Communication can become more complex with more people involved. It can only delay surgical intervention if the medical optimization process is not efficient. And it certainly places an increased burden on the medicine or geriatric service. We have to be mindful of these challenges. One of the most important findings from the research is that co-management works best when it's a part of a larger multidisciplinary effort. This JAMA network open meta-analysis from 2020 is very telling. It found that co-management alone was not significantly associated with a shorter length of stay or lower mortality. However, when co-management was combined with a dedicated multidisciplinary team, including nurses, physical therapists, occupational therapists, and social workers, the results were dramatic. Patients had shorter hospital stays by an average of 2 days and significantly lower mortality rates. This underscores that success isn't just about two physician teams working together, it's about the entire system of care. So based on the evidence and practical experience, there are 5 keys to building a successful co-management program. 1, clarify roles. You must have a written agreement that clearly outlines the roles and responsibilities of each team, who is the primary contact for the family, who writes which orders. Number 2, identify champions. You need physician champions from both the surgical and medical departments to advocate for the program and navigate institutional barriers. Number 3, address finances. The system needs to recognize the work being done. You have to address how the program will be financially supported. Number 4, measure performance. You can't improve what you don't measure. Track metrics like clinical outcomes, patient satisfaction, and efficiency to demonstrate the program's value. Number 5, quality improvement. This should be a living program. Establish a process for continuous review and adjustment to address any issues that arise. Let me share a couple of real-world examples that illustrate the value of this program. So case number 1, we had an 82-year-old female with mild cognitive impairment and multiple medical problems who fell and fractured her hip. She was admitted overnight to orthopedics. For her pain, she was started on gabapentin and 10 mg of immediate-release oxycodone as needed. Overnight, she developed altered mental status and a rapid response was called. When the geriatrics co-management team came on board the next day, we immediately identified these high-risk medications. We discontinued the gabapentin and oxycodone, switching to a multimodal regimen with Tylenol, a lidocaine patch, and very small dose of IV dilaudid. We also switched her loratadine, which has anticholinergic properties, to a nasal spray. Her delirium improved, and she was able to proceed to surgery safely. Case number 2, an 87-year-old male with BPH, atrial fibrillation, and heart failure, also presented after mechanical fall and hip fracture. The fall was initially labeled mechanical, as I stated. However, on day 1, the geriatrics team took a deeper history and discovered he'd had several presyncopal episodes over the past 2 weeks. It turned out his tamsulosin for BPH had recently been started and titrated up. His orthostatic vital signs were positive for hypotension. We called his outpatient urologist, adjusted his BPH regimen, and provided education and lifestyle modifications to prevent falls. This was a classic case where we identified and addressed the root cause of the fall, not just the resulting injury. So these cases highlight the specific skills required for this work. They fall into 2 main categories: excellent general medicine and specialized geriatric medicine. Under general medicine, we need to be experts in preoperative evaluation, managing diabetes or blood pressure, pain control, bowel regimens, and secondary fall prevention, including osteoporosis management. Under geriatric medicine, we bring a specific framework to our assessment, which we call the Geriatric 5Ms. We'll spend the next part of the presentation diving into this framework. But first, a quick word on preoperative risk assessment. So for preoperative evaluation, we use several risk calculators. One of the most common is the Revised Cardiac Risk Index, or RCRI. It uses 6 simple clinical predictors like history of heart disease, diabetes on insulin, or an elevated creatinine to estimate the risk of a major cardiac event after surgery. As you can see from the MedCalc screenshot, patient with 0 points have a very low risk, while a patient with 3 or more points has a risk of 11% or higher. This helps us decide who needs further cardiac workup. A more comprehensive tool is the American College of Surgeons NWESQUIP Surgical Risk Calculator. This is an online tool where you can input the specific surgical procedure along with dozens of patient factors. What's particularly valuable for our population is that you can add specific geriatric outcomes with this calculator. It will then calculate the patient's individual risk for a whole range of complications like pneumonia, surgical site infection, and even death. But it also predicts the risk of things like postoperative delirium, functional decline, and the need for a new mobility aid. This is incredibly useful for counseling patients and families and for proactive care planning. Now let's turn to the core of the geriatric assessment, the 5Ms. This framework was developed to help ensure that we are always focusing on the key issues that affect all adults. The 5Ms are mobility, mind mentation, medications, multi-complexity, and what matters most. These are the 5Ms. So let's start with mobility. I'll pose a question to you all. Which of the following interventions does not reduce the risk of falling? 1, medication optimization. Number 2, exercise. 3, call alarms. 4, home safety assessment. And 5, nutritional interventions for patients with malnutrition. Okay, the answer is number 3, call alarms. While call alarms are important for their, their purpose is to shorten the time a person spends on the floor after a fall, but they don't prevent the fall itself. The other 4 are all evidence-based interventions to reduce fall risk. So for mobility, our focus is on fall risk screening, like checking orthostatic blood pressure and implementing interventions. We also perform a thorough assessment of a patient's ADLs and IADLs to understand their baseline function and set appropriate goals. And we ensure they have the right assistive devices. Next is mind. Another question for you. Which of the following is not included in the confusion assessment method or CAM for diagnosing delirium? 1. Acute or fluctuating clinical course. 2. Inattention. 3. Disorganized thinking. 4. Memory loss. And 5. Auto level of consciousness. So the answer is number 4, memory loss. While memory loss can certainly be a feature of delirium, it's also a hallmark of dementia. The CAM algorithm specifically relies on acute onset, inattention, and either disorganized thinking or on auto level of consciousness to make the diagnosis of delirium. So when we think about mind, we focus on the 3Ds, delirium, dementia, and depression. For delirium, our primary tool is the CAM, as shown here. And for dementia, we look for any prior cognitive assessment in the chart, and if needed, we can perform a simple bedside screen like the mini-cog, which involves 3 words registration and a clock drawing. And for depression, we can use a quick screening tool like the PHQ-2. It's crucial to assess all 3 of these domains. The third M is medication. Which of the following does not have an anticholinergic burden based on the ACB scale? 1. Cimetidine. 2. Diphenhydramine. 3. Escitalopram. 4. Gabapentin. 5. Meclizine. Okay. The answer is 4. Gabapentin, which has a score of 0. The others all have a score of 1 or 3. Anticholinergic medications are a major cause of confusion and falls in older adults, so minimizing this burden is a key intervention. Managing medications in older adults is complex. We rely on several key tools. The ACB calculator shown on the left helps us quantify the total anticholinergic burden. In the middle, we have the American Geriatric Society Beers criteria, which is a list of potentially inappropriate medications to be avoided or used with caution in older adults. And on the right, we use tools like Lexicon to check for drug-drug interactions. A thorough medication review using these tools is essential for every patient. Our fourth M is multi-complexity. This refers to the fact that older adults often have multiple chronic diseases, fundamental functional impairments, and social challenges. A key concept here is frailty. So another question for you. Frailty is associated with an increased risk of all of the following except 1. Discharge to assisted living. 2. 30-day mortality after cardiac surgery. 3. Length of hospitalization. 4. Readmission. And 5. New tariffs. The answer, of course, is new tariffs. All the others are well-documented adverse outcomes associated with frailty. As this slide highlights, and a shout out to my colleague Dr. Fred Koh for this content, frailty is a powerful predictor of surgical outcomes across many specialties. In cardiac surgery, it's linked to higher mortality. In urology, it predicts discharge to a facility rather than home. And in cancer surgery, it's associated with longer hospital stays, higher readmission rates, and worse long-term survival. So assessing for frailty is not an academic exercise. It has a profound clinical implications. We can assess for frailty at the bedside. One simple tool is the Frail Scale, which is a 5-question screen asking about fatigue, resistance, climbing stairs, ambulation, walking a block, number of illnesses, and loss of weight. Another widely used tool is the Clinical Frailty Scale, or CFS. This is a 9-point scale that uses clinical descriptors and pictures to categorize a patient's level of frailty from very fit to terminal ill. This gives us a quick, holistic assessment of a patient's vulnerability. This brings us to our final and arguably most important aim, what matters most. This is about aligning our care with the patient's own values, goals, and preferences. A key part of this is knowing who the decision maker is. Let's consider this scenario. A patient's wife passed away. He has 4 children and 2 brothers. He does not have a healthcare proxy. Who would be the prioritized surrogate decision maker based on the Family Healthcare Decision Act? Is it the oldest son, all 4 children equally, the older brother, both brothers equally, or his best friend? The correct answer is 4 children equal surrogates. The Family Healthcare Decision Act, which is a law in New York and many other states, specifies a hierarchy of surrogates. After spouse, adult children are next, and they all have equal standing, regardless of age. Understanding this legal hierarchy is critical when a patient loses capacity. But matters most goes beyond just identifying a surrogate. It's about having conversations with the patients and families about their goals. What does a good outcome look like to them? What are they hoping to achieve with this surgery? What are they not willing to sacrifice? These conversations guide our medical recommendations and ensure the care we provide is truly patient-centered. So to summarize, the 5M framework provides a comprehensive structure for our geriatric assessment. We systematically evaluate morbidity, mind, medications, multi-complexity, and what matters most for every single patient. To make this systematic approach practical in a busy clinical setting, we've operationalized it within our electronic health record. This is a screenshot of our geriatric co-management note template. As you can see, it has dedicated sections for each of the 5Ms, as well as recommendations for care transitions and advanced care planning. This ensures that we consistently address all of these key domains for every patient we see. As we conclude, I want to leave you with three main takeaways from our discussion today. First, the co-management model is a powerful tool that can improve clinical outcomes and increase satisfaction for both patients and providers. Second, the success of this model hinges on a multidisciplinary approach. It's not just about the doctors, it's about the entire team working together. And finally, as geriatricians, our unique contribution to this model is our expertise in both general medicine and the specific application of the geriatrics 5M framework. By focusing on these principles, we can provide immense value to our surgical colleagues and, most importantly, to our older patients. Thank you for your time and attention. I'd be happy to take any questions. Thank you.